It is now my distinct pleasure and honor to welcome Dr. Sania Nishtar to the podium, the Chief Executive Officer of Gavi, the Vaccine Alliance, and one of the most consequential voices in global health today. As a medical doctor, Dr. Nishtar has built an outstanding career over 30 years as a national and a global leader. She served as a senator in her home country of Pakistan, as Special Assistant to the Prime Minister on Social Protection and Poverty Alleviation, as a federal minister with responsibility for the Ministry of Health. Dr. Nishtar has fulfilled several leadership positions in civil society, in international organizations, and founded a health reform organization think tank in Pakistan. She's co-authored dozens of influential papers and books and published in leading newspapers. As a graduate of Khyber Medical College, Pakistan, and also King's College, London, she has received numerous international awards, and in 2020, the BBC named her among 100 inspiring and influential women around the world. We're absolutely honored to have you with us today, and I welcome you to the podium. Thank you.
Good morning to all of you. Let me begin by saying how truly honored and deeply grateful I am to be here. And thank you, Louise, for the very kind invitation. Thank you to the Global Health Institute for organizing this symposium for the 4th year running. I think, Louise, you painted a very appropriate and a sobering picture of where we stand, and I don't think I can add to that, except saying that we are living in truly unprecedented times. But I so liked the foreword in the subtitle of the symposium, because I think we are where we are, and we now need to think about where to go from here and to take the remedial action that the world so desperately needs. I decided not to go into the definitions of global health because that would have taken me half an hour, and I'm very practical. I like to be solution-oriented. But how do we get to the stage where we are in terms of the architecture of global health? And if you look back into history from the colonial times, there was a time when we used to talk about tropical medicine. Then came the era of international health with a focus on technical assistance. Then was the decade of the Alma-Ata Declaration and a focus on primary health care, which was followed by the movement of structural adjustments. Subsequent to that, in the 90s, there were a number of different things that moved together. There was a focus on product development partnerships, some very influential product development partnerships, which did extremely well in reducing mortality and morbidity in some of the most disadvantaged settings of the world. At the same time, the HIV and AIDS emergency came up, and several instruments were created to combat that. And of course, at the same time, things started shifting. So from the year 2000 onwards, there was a proliferation of global health institutions, large global health institutions. And at the same time, the world came together, the then G8, which had a lot of fiscal space, created a compact called the Millennium Development Goals. And all the developing countries aligned behind that. I worked in Pakistan then, and I saw how all developing countries aligned behind the Millennium Development Goals, the time-bound outcome-based goals. And subsequent to that, a number of institutions were created. Gavi was created in 2000. The Global Fund was created in 2002. PEPFAR was created in 2003, and a number of other very large bilateral instruments were created by the United States around the same time. Fast forward 15 years, and then comes the era of the SDGs, where there was an increasing realization to the importance of systems development. And now we are 4 years before the culmination of the SDGs at a crossroads. where things have dramatically shifted. There always was a realization that there will be a new era of development after the SDGs, but it has just been preponed in the context of where we stand today and the very eloquent rundown that Louise gave just a moment ago. So if we look at from tropical medicine to the SDGs, I think as a starting point, we need to be very proud of ourselves because a lot has been achieved. During this time, and I'm not saying that this is by any stretch of imagination, that this was the result of the institutional architecture, because there were several technological and therapeutic advancements, the social conditions improved, per capita income improved. And as a result of that, of all these changes, we gained 10 years in life expectancy. There was a 60% reduction in under 5 mortality. There was a 40% reduction in maternal mortality. 75 million deaths during this time frame were reduced due to vaccination alone. Another 25 million HIV/AIDS related deaths were averted due to the countermeasures in that space, and 13 million malaria deaths have been averted during this time frame. So I think there is reason to be there's a reason to celebrate what was achieved, notwithstanding the shortcomings of the global health architecture, because you will hear a lot today and going forward about the shortcomings of the global health architecture and the need for reform, and we should completely stand behind that. But we should also not forget that the architecture we developed, the investments that we made, have really yielded dramatic results. And it is very important that in any new structure that we create, these gains should not be compromised. That realization is very important because we are seeing the beginnings of that. Last week, the OECD came up with a report, and the report basically showed that there has been the single largest reduction in ODA when you compare 2023 with 2024. It's the single largest reduction in ODA, 23.1%. And early outcome-based data is showing that the trend in the reduction of under 5 mortality is sadly beginning to reverse. So we really have to act, and we have to act quickly to protect the gains that we have so painstakingly made over the last several decades. In order to make change, we have to read the landscape, and we have to read the context. And I think there are some important changes that we must bring to bear. The first change is that there is now an ideological decision to reduce ODA, official development assistance, and to scale down official development assistance. And this is not something that is related to the rapid shutting of the doors of USAID. This was something that was on the anvil for a very long time. At least as far as 6 to 7 years ago, we saw development agencies absorbed into ministries of foreign affairs. Even as a new CEO of Gavi 2 years ago, when I took a round of all the donor countries, I could see each one of them saying, we have decided to cut back on ODA because we have competing priorities, because we have to cater to internal migration, because defense spending is now an imperative. And of course, conflicts are increasing, and this situation will further perpetuate. So the ODA decline is something that is real, it is happening, and it is not confined to the United States. It's a worldwide trend. Even countries with surplus budgets are telling me we have taken a decision to cut back ODA. So that's the one change. The other change, and here you will see a silver lining, there is a movement to promote national sovereignty. So if you go to Africa and if you speak to heads of state, they will tell you, we want to be health sovereign. And for us, health sovereignty means the ability to indigenously mobilize resources and the capacity to accrue the benefits of those domestic resources to our populations in terms of primary health care, in terms of basic education, and we are willing to invest the resources that are needed. And we are willing to step away from ODA, but we need a fairer trade deal. We need fairer terms of engagement in the global system. And that's another movement that is playing out. And the third movement which is playing out, and my colleague Yonane is here, some of us are at the forefront of these debates and discourses and institutional restructuring, because there is now a very clear realization that the international development architecture, the international global health architecture needs to change, just needs to change. It is expensive, it is duplicative, it is fragmented, there are competitive behaviors, there are mission creeps, and we cannot afford it anymore. So I think when we talk about reform of the global health architecture, we need to bring to bear these three realities. The systemic decline in ODA, to the extent that it is now irreversible. And I'm not saying this is the end of ODA. There still will be an appetite to spend ODA in fragile settings and in humanitarian settings. But the whole-scale mobilization of ODA, which was the norm in the era of the MDGs, is a period that's over. Secondly, the health sovereignty movements. And thirdly, the appetite within the system to do something radical and to do it fast. So 2 years ago, when I came in as a CEO, I could clearly see the writing on the wall. And I began a reform of the organization of Gavi, which is called the Gavi Leap. And I'll talk about that a little later. But I also proactively engaged in the discourse on the reform of the global health architecture with many of my other colleagues. I think it is very important that we come to an understanding, a collective understanding on what we mean by reform of the global health architecture. What are the levers available to us? And in order to do that, we have to be clear about the objective first. Because the objective and the principles. The principles, of course, drive the objective, and then the objective drives what the process should look like and what agencies are in scope, because we're talking about a plethora of agencies. The objective, as I said, can be different depending on the vantage point. And I'd like to outline 3 objectives in 3 different buckets here, but I have to be mindful of time. So how much time do I have? 24 minutes? Okay. I can take the whole 24 minutes? Okay. I'd like to keep some space for questions and answers. So when you don't have a scripted speech, you tend to go off time. So I want to talk in 3 different buckets. And I want to re-emphasize that the objective can be very different. The process and the definition of agencies that are in scope and the timelines can be very different depending on your objective. And as I said, I'd like to talk about 3 in particular. One objective can be addressing the fragmentation, duplication, and the issues that exist at a country level. And I put on my hat of a former government official in Pakistan. How does a Minister of Health perceive the global health architecture at the local level? It's extremely fragmented. You have 10 to 15 UN agencies, you have Gavi and the Global Fund, you have a number of different philanthropic organizations, you have the World Bank, you have 3 to 4 regional development banks, you have a number of bilateral agencies, each one of them with good intentions, each one of them wanting to support, but each one of them has unique demands of the ministry. They want they have their own grant cycles, they have their own accounting systems, they have their own procurement systems, they have their own guidelines. Each one wants a separate audit. Each one has different country teams. Each one wants a different set of meeting with you, and each one of them wants a different institutional arrangement. So from morning to evening, you're going to the committee, the governing committee of Gavi, to the management committee of the Global Fund, to the steering committee set up by the then USAID, to the technical committee of DFID, and so on and so forth. There's huge fragmentation. And each one of them has a separate task. If you go to a primary healthcare center in any developing country, under the same roof, you will see that the contraceptives are provided by UNFPA with their own supply chain, with their own procurement systems, with their own HR personnel, with three levels of institutional hierarchy. The vaccines are provided by Gavi. The TB drugs are provided by Global Fund and 4 or 5 other agencies as well. RUTF is provided by UNICEF. RUSF is provided by the World Food Program. The list can go on and on. So depending on how much the child weighs and the level of malnutrition, you go either to the World Food Program kiosk or you go to the UNICEF kiosk. These things are duplicative. They pose a huge administrative burden on ministers and officials, and this really needs to change. If we as global health actors, and I put back my international hat, if we are serious about remedying the failings of the global health architecture, this is the one separate objective we must have. And this has nothing to do with the conversation of how we're going to reform institutions in Geneva and New York and in Washington. This just requires a consensus by the donors to cede their authority, to cede their power to the local level, and to put all their resources at the disposal of governments with bolstered checks and balances. And I must re-emphasize, with bolstered checks and balances. And this is one separate objective. What is the second objective? The second objective is regarding, and by the way, on the first objective, we are calling this in our own parlance as merger at the last mile. We're saying it is not just reform of the global health architecture, it should also be reform of the local health architecture with its very different process, very different objectives, very different stakeholders, but very strong principles and an alignment by the donor community. So that's number one. The second objective is, what are you going to do about issues at the global level? There's a proliferation of organizations, and the way we do our fundraising, we are competing against each other. Let me be quite honest and candid here. There are lots of mission creeps and competitive behaviors, and there are no incentives to stay in your lane. Which is why when I'll talk about the Gavi leap later, our own reform process, but one of the principles of the Gavi leap is focus mandates. Because currently there are no incentives to remain focused on your lane. There is an incentive to proliferate because we all compete for resources. And there is a way to remedy the duplication and fragmentation, but we have to be very brutal about that. And we have to be, there has to be an independent process analyzing and then coming to a consensus. One part of, and of course as part of that equation, there's huge potential to merge entities, sunset entities, and to come up with a smaller, more agile ecosystem where entities have very clear mandates and a disincentive to expand their mandate, and a mechanism to bring agency heads together in a coalition which is institutionalized. And this is one of the recommendations that I gave in a Lancet paper which was published in January. It was called the Global Health Leap, an urgent call to action. But as part of that effort, I think there are some hard questions that we must address, because those hard questions are often sidestepped. One of those hard questions relates to the definition of ODA itself. Because we lump development assistance with the assistance that should finance global public goods. Global public goods such as global health security, pandemic prevention, norms and standards, cross-border transnational regulation. And these are the kind of global public goods that benefit every country of the world. And every country of the world should should support and pay for the maintenance of this ecosystem that serves all of us. But aid is something else. Development assistance is something else. It's not the same as the financing of global public goods. And there are examples in the world. For instance, the airline regulator, as far as I know, is maintained by contributions that come from every country. And we need to develop a similar system in global health to support global public goods and mandates such as pandemic prevention and response and norms and standards and regulation. And of course, aid and development is a different matter. That's one hard question that we need to address. The other hard question is about the competitive behaviors. Because back in 2024, when MPOX struck, we literally saw regional and global institutions competing with each other. And there needs to be clarity on who does what. Thirdly, and in terms of putting the hard questions on the table, does reform of the global health architecture just mean the global health institutions, or are we going to take a one health approach? Are we going to put development intermediaries in the mix as well? That's something else we need to ask ourselves and address. What about fragile settings? As ODA is declining, are we going to abandon fragile settings? And how are we going to protect the fragile and humanitarian settings? And what kind of new risk appetites do we need to develop to cater to those? What about missing competencies? Because we take it as a given in our current discourse that we need to shrink the global health architecture, but there are some missing competencies within this space as well. Some of us were at the Munich Security Conference in February. The entire discussion of the Munich Security Conference from a global health vantage point was centered around the new biothreat centered on AI. So AI poses bioterrorism threats of a kind that people like us, are even beginning to understand the implications of. And we need to develop institutional competencies within the global health architecture on the global public goods side to be able to counter that. What about NCDs? 1 in 3 people in the world has high blood pressure, 1 in 4 has diabetes, and obesity is rampant. NCDs are on the rise. But the way the global health architecture is currently designed does not cater to NCDs. You need to work with the private sector to avert threats, and we have no mechanism, institutional mechanism to do that. When I was the chair of the High-Level Commission on Non-Communicable Diseases, it took a huge drama for us to have a 5-minute interaction with the Cokes and Pepsis and McDonald's of the world. Huge drama. In-camera conversation with them for just 5 minutes. The world does not have the capacity to sit with these actors because they have solutions for NCDs. We're not even talking to them. So there are these centered on the global regional tensions and the role of AI and bioterrorism, and the possible support for fragile settings and the missing competencies and so on and so forth. There are a whole host of tough issues that need to be put in the table when we talk about design of the global health architecture. And my worry is that although we strongly believe there's a consensus that the World Health Organization is the right lead agency to be shepherding these conversations, but some of us worry because the member state process inherently is such that you are left with consensus on the lowest common denominator, and some of the tough issues do not come to the fore. And finally, the third bucket that I wanted to talk about was, what do you do in the new global health architecture? What do you do with these institutions that have delivered wholesale impact on the ground, institutions like Gavi and the Global Fund? I mean, in humility, I'd like to say Gavi as an entity has vaccinated over 1 billion children. saving 20 million lives, accrued $52 of economic benefit for every dollar invested in Gavi. We work at a 3% operating cost. And I again want to say in humility, we're the poster child of what development should be in the future because we show countries the pathway to transition and for countries to exit. And our sister agency, the Global Fund, delivers similar impact in 3 disease domains. Massive benefits to the humanity. And as we go forward, what is the future of organizations that deliver impact, wholesale impact? Gavi and the Global Fund are 2 of them, but there are smaller product development partnerships as well. How are we going to design the transition plans that will allow countries to take over responsibilities without creating the adverse effects that the sudden pullout of USAID did? My apologies for raising this, but it is a fact. We need to prepare well-designed transition plans. So these 3. I just wanted to bring to bear the complexity of the nature of the discourse, the complexity for planning and execution, and the need for clarity in objectives. You want to make a change, to summarize, you want to make a change at a country level. It's a different problem you're solving for. It's a different discourse, and the stakeholders are different, and the process has to be a standalone process. You want to make change at the global level. You want to simplify the architecture. The WHO is the right avenue. But you cannot have a standard member state diplomatic process and end at the end of 2 years with nothing but text that says very little. You have to put the hard questions at the center of the equation. And thirdly, then it is the future of the development intermediaries that have delivered huge impact, and now is a question of how do you transition responsibility to countries. So this is the context in which we designed our own reform called the Gavi Leap. And with the Gavi Leap, we did several things, because what we wanted to do was to design an organization which was fit for a future global health architecture. We've scaled down by 1/3. We've made ourselves far more efficient, accountable, transparent, with tighter controls, with far more transparency, with far more checks and balances, digitizing our key processes, and all that has come to fruition in the last 2 years. We're transitioning many responsibilities to countries, and one of the key things that you have to do when you talk about country transitions is to give them authority and responsibility. You cannot be talking about country transitions and still hold the resources in your hand. And that was a difficult, very difficult thing to navigate with a lot of opposition. But we have and will continue to cede authority and transition decision-making responsibility to countries. We've radically simplified our country operating model. And one of the things that we feel as an organization is very important, that you listen to the countries that you are meant to serve. We exist to serve countries in the South. You must listen to them. So our modification of our country operating model, the radical simplification that we've adopted, is the direct result of what I heard within the first 10 days of assuming office. We've been at the World Bank annual meetings earlier this week and are going back again this afternoon, which is why I apologize. I'll have to leave a little early. And yesterday we were telling them that health sovereignty is a big movement there. Africa wants to be health sovereign. They want to manufacture their own vaccines. They want to manufacture their own medicines. They have a goal. They want to achieve that goal. At Gavi, we put a subsidy instrument, and then we went back several times and listened to them. They wanted modifications in that subsidy instrument, and we've gone back and made those modifications. So just to end, as I look at the watch, I realize I've taken more time than I ought to have. Yes, we are talking about reform of the global health architecture, and yes, there's a collective conversation about objectives, and about goals and about processes and about collaboration and engagement. But that should not preclude us all from making the changes within our own organizations that will make us fit for the next 15 years after the SDG, starting now. We've embarked on that journey. And I'm really grateful to all my colleagues who have been such an important part of that transformation. And I'm grateful to our board for their support, and grateful to all the stakeholders and academic colleagues who have supported in this effort. So let me stop here and hand it back to you, Louise.
Thank you. We do have time for some questions, so thank you for saving time for that. Maybe we're going to go first to our online audience. I know they're always really keen to engage, and we have Princess who's helping to manage those questions. And if others in the room have questions, please do raise your hand, and then we'll be having you use those microphones on your table. So thank you, Princess.
Thank you so much. We have one question online. Incidents like the recent HIV outbreak in Pakistan suggest that enforcement alone isn't enough. What systemic factors allow basic safety protocols to repeatedly break down, and what kind of accountability model would prevent this from reoccurring?
Shall we take a few?
Yeah, let's take a few. Jessica. And would you mind introducing yourself briefly? Thank you.
Hi, I'm Jessica Haber. I'm at the Center for Global Health with Louise. So I really appreciated your comment about the competition that we have amongst each other, which I think is real and really stifling. You mentioned the need for consensus and trying to find a way forward and not seeing our work as a zero-sum game in many ways. And I wonder if you could comment some more on who do you think should lead that consensus effort? Because that itself, I think, could be an important starting point, but also a stumbling block. Thank you.
And do we have another question in the room? And then we could maybe... Shy audience warming up. We'll maybe start there, please.
So in Pakistan, HIV, the resurgence, as you know, prevention is a societal responsibility. And of course, the health system has a very important role to play by reinforcing the preventive behaviors, and we simply fail to do that. That's a simple answer to that, and that should teach us a lesson. On the consensus efforts, as I mentioned, the discussion on the reform of the global health architecture is not a nice and fluffy conversation on which 200 member states of the world are going to weigh in and we are going to come up with the lowest common denominator. I don't think it should be a traditional member state process. Many of us do believe that the World Health Organization is the right institution to lead that. But the WHO Director General has a lot of authority, moral authority, and power to design processes that are fit for the outcome that is to be achieved. And I believe that it is entirely possible for the World Health Organization Director General to put in place an independent process and then make the findings and the recommendations of that independent process seriously binding, and then shepherd the process of reform. Because this is not going to be an easy sell. Different countries have their pet institutions and have a disincentive to see those institutions merge or disintegrate or scale down or acquired. But this is something that needs to be done. If we want to tidy the global health architecture, if we want to scale it down, if we want to make it nimble and fit for purpose for the next 15 years, for the next decades to come, some tough decisions have to be made. And it is only the World Health Organization that has the moral authority to shepherd this process. And they need to be very, very courageous in this effort.
Dr. Barnos.
That was really inspiring, and I hope this question is not too granular. It was wonderful to hear about the transition of responsibilities and authority to local countries, to local governments within countries. And I had a question about vaccination, and specifically the HPV vaccination. If countries decide based on evidence, for example, to vaccinate older adolescents, to vaccinate boys, is this something that Gavi would be able to support?
It's a question of resources. You see, it's a question of resources because we've recently done our replenishment, which, as you know, is in our parlance the word for fundraising for our next 5-year strategy cycle, which kicked off this January. We had an ask of $11.9 billion. We were able to secure 10, which in the current environment is a very good outcome. And there were many new donors, which was a very pleasant surprise. But we are short, 2 billion short of our target, and we had to make many adjustments to our program. So it ultimately, the short answer to your question is yes, but it's a question of the availability of resources. And we are currently fine-tuning and slightly curtailing our programs so that we don't water down our ambition, but still deliver with recasted programs. Hopefully when resources are available, it's a different matter.
We have another question online, and then I think we would have time for one more in the room if anybody would like to raise their hand. Let's go there first, please.
Oh, thank you very much, Sania. Claudia Peixoto from PAHO WHO. And thank you for your reflections, but it's something that has been resonating in my head when you talked about health sovereignty, because if there is one of the effects of the pandemic, I'm talking on the aftermath, has been the reduction of immunization rates. And there are new, let's say, even sickness that have been already eliminated are resurging. So there is this, and this is happening. How is it compatible that you have this appetite for health sovereignty versus this decrease in immunization rates, when immunization is one of the basics of primary healthcare, for example? Thank you so much.
Thank you. And the last question, Princess, from online.
Yes, so the question is, as you mentioned, we are all competing for funds, but how can local NGOs and existing local civil society organizations increase their impact?
Sorry, could you come again? How could
local NGOs and local civil society organizations increase their impact?
Okay, so very quickly on the question from a colleague from PAHO on the resurgence of diseases that were once eliminated in geographies and its interplay with the health sovereignty movement. So the health sovereignty movement is coming primarily from the African continent. And of course, there are problems of vaccine information there as well, but we do not see a decrease in appetite. We don't see a decrease in demand. In fact, there is so much demand for vaccines from the African continent that we are unable to fulfill that demand. The malaria vaccine is a case in point. We had the fastest rollout of the malaria vaccine in the history of vaccination ever. 25 countries adopted it in 2 years. And there's so much demand that we are unable to fulfill that. The problem of resurgence of eliminated diseases in geographies is coming from the north. I was speaking at the UK Parliament, and the first thing the chair said to me was that today is when we lost our measles-free status. You switch on the television in Canada and you're hearing about measles outbreaks. In your country, this is happening again. And the determinants of that are things that you're well aware of. Let us not go there. But to be very honest, after the pandemic, we seem to be suffering from a collective amnesia because the pandemic brought the world to a standstill. It inflicted pain on this planet of a magnitude that we have not seen before. And by every measure, we should be all rallying up to, to gear up to protect ourselves from the next one and to make sure that we have the response measures in place. But here we are at the World Bank Spring Meeting week, trying to make a case for pandemic level surge financing. And that to me indicates that we all suffer from collective amnesia. But thank you for that important question. On the role of local NGOs and civil society, so the civil society plays different roles. The civil society sometimes has roles that are very different. At times it needs to advocate. At times it needs to be an honest voice. And at times it has to be in a contractual relationship to execute on the ground. And it depends on the color and flavor and construct of the civil society group. Not all civil society groups are alike. They have different mandates, they have different missions. Some of them cast themselves more as expert groups and technical groups that are an honest voice, that advocate, that lobby to governments, particularly in the developing countries on thematic areas. And then there are others that mold themselves more as delivery agents and then work. It depends on how you want to position yourself. But from our work in Gavi, we know that the civil society plays a very important role. The civil society sits on the Gavi board. They're advocacy partners for us. They help us mobilize resources, and they help us deliver on the ground in very different settings where governments are either unable to operate or are unwilling to or are not allowed to. And that's where the civil society really comes in. Becomes really very useful for us. And I have enormous respect for the work they do.
Thank you, everybody, so much. Thank you so much, Dr. Nishtar. It's been an honor to have you here. We really appreciate you and your words. Please join me in thanking our keynote speaker.
Thank you. Thank you, sir.